Hello and welcome to this webinar, Enabling NHS Resilience Hubs Staff Support Post-COVID. Please do like the video by clicking the thumbs up and press subscribe to receive notifications for any future content. It gives me great pleasure to introduce our first speaker, Byron George. He is the CEO and co-founder of PCMIS. Hello, Byron.
Good afternoon, everyone. Perfect. Okay, so thank you for the introduction. So I'm Byron George, and obviously as mentioned, I'm Chief Executive Officer and co-founder of PCMIS. Now, I've a chartered IT professional by trade with 25 years experience of implementing large-scale healthcare solutions. So if you're not familiar with PCMIS, we do provide digital mental health case management solutions and able to support a wide range of complex pathways which can be linked to single electronic patient record, and including like pathways, staff wellbeing hubs, Covid-19 pathways, and a wide range of other services. I'd just like to run through. So before I hand over to Alan and Helen, just want to give you a bit of a brief overview of recent service transformations, an insight into how we've worked with NHS England, commissioners and services to introduce new digital tools to support the current service delivery challenges. And I think we're all aware of, the various challenges we're experiencing. And how we sort of introduce digital pathways for existing services and new services such as the resilience hubs. So in terms of what we know, we know mental health services experienced significant transformation and challenges over the last year. I mean, this graph, for example, does highlight the dip as we went down into the first lockdown last year. But data analytics shows that the activity is starting to return back to expected volumes. However, we also do know that with many staff still remote working, limited face-to-face contact, maximising the use of technology continues to be an essential part for services. So one of the ways we've been able to help respond and support services is by using the patient portal, which is a mechanism to allow patients to submit their measures online, including ADSMs as part of their treatment. And as you can see in the graph, usage has increased. We're reporting an incredible increase of 637% from sort of pre-lockdown. Even up further, I reported 404% early in the year from one of our previous presentations, and we're predicting growth is still going to continue. So it does show that services are, investing in trying to optimise services even now in terms of using digital tools to be able to help achieve that. So the way we support that is one of our new options that we can offer services in terms of the portal SMS. So this helps to extend the digital pathway for patients. It increases patient engagement, and it's been able to sort of maximise clinical contact time. So we send a SMS to the patient which contains a unique web link, and it allows patients to complete their measures online very easily and very quickly. And in terms of the company, our overall aim is to try and make a difference to people's lives through evidence-based research and innovative technology. So therefore, it's really important for us to evaluate the effectiveness of the digital tools that we do offer. So in terms of data analytics, we found that the portal SMS is having a positive impact on the number of patients completing the measures online. So the graph you see here is a really good example where we've implemented the portal SMS in December, and we've seen a significant increase from a 14% patient engagement up to a 67% using the portal SMS. And what's interesting as well is we've seen sort of a consistent approach. It's always a challenge between implementing new technologies for new services and, in contrast, using digital tools to transform existing processes for existing services. So what we're also seeing is a consistent increase in patient engagement across all different types of service models. And as you can see, these two graphs do look different. So where the previous example shows an existing in-house administration process was previously being used, and a dramatic transformation when switching to an automated digital tool. To services where portal technologies were more established, but are still seeing a benefit and increase in engagement and uptake. So just a small increase, we look and estimate that just even a 10% in increase in patient engagement using such online portal technologies will save over 100 hours of administration and clinical time each month. So it does allow services to maximise that valuable clinical time rather than having to complete manual forms. And in this case, it basically means that 7 out of 10 patients are completing their measures online, reducing a significant amount of paperwork needed. Our analytics all show it's a really encouraging response rate as well. So we're seeing a 68% click response to the text messages. What's encouraging as well is we're seeing a 68% response rate in terms of the click. So it's really nice for us to be able to, have the ability to sort of track and analyze, the response rates as well. So it's a really good comparison in terms of email. So typically we're seeing, sort of nearly 3 to 4 times better response rates than typical emails, and it doesn't suffer then in terms of emails getting lost in spam, and not being delivered and so forth. So we're finding it's a really efficient and effective mechanism in terms of engaging with services and service users. Now, this then sort of brings me on to the resilience hub implementation. So we've worked very closely with Helen and Alan for many years, probably far too many than I care to remember. But from the very early days of working with Helen at a commissioner level, commissioned some of the very first IOP services in children's mental health services, through to working in partnership with the Trust to develop the PCMIS to support the Manchester incident response pathway back in 2017, and obviously to the more recently implemented resilience hubs. And it's really interesting to sort of compare the digital transformations between sort of a digital first approach. So this graph here shows you the difference between a service that has gone through the transformation over the last year, and we've typically seen a sort of 83% increase in e-referrals for services that were using the systems prior to lockdown. Now, in contrast to the resilience hub, going for a digital first approach, the amount of e-referrals, the percentage is significantly different, with an average here of 98.61. It basically means we've been provided the tools for the service from the outset, and it means they can have very efficient and very effective processes right from the outset. So in terms of how we've supported the service, we've worked in partnership. We've been able to develop some really nice bespoke and neat tools in terms of supporting the resilience hub. So we've introduced some new digital tools. We've got some nice customizable e-referral forms appropriate to the context of the resilience hubs, and introduced an intelligent screening logic. So it does allow services to streamline the referrals and very easily and quickly identify priority patients, which is obviously a very important aspect of risk management. And it does mean then services can realise the benefits of these sort of digital pathways immediately. And I don't want to sort of give you too much information here, but I will now hand over to Alan and Helen so they can share their experience, their very hard work in implementing their resilience hub, and allow them to explain a little bit more. And it's really nice, and I think just a bit of a hats off to Alan and Helen as well, because their resilience hub is seen as a national exemplar. So I'll end my presentation here. The slides will be shared by SBK. I've left my contact details here if there's anything you like further information on from what I covered.
So I'm Alan Barrett. I'm a consultant clinical psychologist, and for the last 10 years I've specialised in psychological trauma, especially military trauma, including supporting people with the impacts of improvised explosive device incidents. And I worked alongside Helen, who will introduce herself later on in the presentation, in that service for the last 10 years. And it made sense that when we had the Manchester Arena bombing, that, that we were asked to get involved within a few hours of the incident. And what you'll hear in this brief presentation is a brief overview of the Manchester Arena incident and the response to it, the psychosocial response to it. And then I'll talk about the approach that we had regarding looking after the support needs of health and care staff, and what we lifted from our previous learning and have placed into the post-COVID support world. And then Helen will conclude with some information around some of the challenges. So let's start with a quick overview of the incident, which you'll all be aware was 4 years ago at the weekend that's just been. So a brief background, Manchester, as most of you on the call will know, city in the north of England, population of just under 3 million people. It's home to some of the busiest indoor venues in Europe, one of which is the Manchester Arena, shown here on the bottom left. It's a 21,000 capacity venue right in the centre of the city. And it has got 3 main exit points. And the one highlighted in the bottom right is known as the City Room. It's a foyer area that joins the auditorium and the adjoining car park, as well as one of the mainline train stations at Victoria. So on the evening at 10:30 on the Monday night, on the 22nd of May, a suicide bomber placed his improvised explosive device packed with nuts and bolts in that area of the City Room foyer as parents were collecting their children from a pop concert, and it resulted in killing himself and 22 other members of the public. It injured more than 350 people who had to attend up to 43 different hospital sites in the UK. The physical injuries were all related to shrapnel injuries, head, brain, neurological injuries, burns, spinal injuries, disfigurements, mobility problems, etc. The emergency response involved just over 2,500 individuals over those first few weeks from all of the emergency services. So we knew very quickly that we had a major incident, mass casualty incident, and that there would be lots of accompanying mental health impacts. So the attack was on everybody. It became clear very quickly that this was going to have to be an intergenerational support package that we had to pull together because of the age of the audience, lots of children. So we very rapidly knew that we were going to have to pull together child services with adult services, with specialist services like the one that me and Helen were working in with military veterans, which was across a whole regional footprint, and work with our other stakeholders to make the response fit for purpose. So I proposed an outreach and screening model that was influenced by the London 7/7 terror attack screen and treat model. And then we set about establishing a physical hub, which was staffed by part-time clinicians from both the adult workforce, the child workforce, and importantly, we borrowed staff from each of the 4 mental health trusts that operate in the Greater Manchester region. We needed a clinical information system. We decided to go with PC-MIS because it was familiar to us. It had served us well, offering a regional service with military veterans. It was adaptable, so we knew that we could make adaptations so as we could report on fields that we wanted to report on. And it got over any barriers that a lot of trusts have around firewalls and IG and permissions, etc. So being a web-based platform where we could just say to each of the trusts, we're just going to give you a license to get on and share our data, was really valuable and allowed us to kind of operate very quickly really in the space. So the first question really, and I suppose this will be true of all of you who are setting up wellbeing hubs to support staff after COVID, is how are you going to know who's been impacted? And we knew that we needed to ask the people who were present as to whether or not they were impacted. So we felt it really important to write to everybody, to let them know that we were thinking of them, to check on how they're doing. And it was quite clear in our system that we did not have the capacity to assess up to 21,000 individuals for a psychological impact. So the next best thing was obviously to do some screening. We decided to do a digital screening, and I'll talk about that shortly. So with regards outreach, comms was really important. We used broadcast media, radio, traditional media, lots of digital media, and some of the outreach to children especially was recognised as kind of best practice. So we were fortunate that this was a ticketed event, so we had a fairly good idea as to who was present, and we had some IG issues which I won't have time to go into here. But effectively, we ended up writing out electronically to all the ticket purchasers who had bought from one of 3 main ticket providers, which accounted for 98% of the tickets. Within that e-invitation, there was a screening link, and this was the beauty of us adapting the PCMIS portal, because it allowed us to send out an individualized link to persons that we were interested in, and they were invited to take part in a wellbeing screening. So they would follow a link that populates some pretty usual minimum data set measures, things like PHQ-9, GAD-7, WASAS, some trauma measures and some functioning measures, and they would then press submit. They'd get an automated bounce back email because the algorithm already kind of RAG rated the responses. So if people seem to be in the non-clinical area, they would be informed that although screening is not everything, please phone us if you need some help. But basically that we sent them out some links to some good quality resources, and we didn't sort of outreach any further at that point because we knew we had to manage expectations of what might be several thousands of people. If people were in the clinical range, or if they were risky, scoring things like item 9 on the PHQ-9 as a 2 or a 3, we would absolutely get back to them and make telephone triage contacts and assess need and facilitate onward referral where indicated. We repeated this process every 3 months in the first year and then every 6 months afterwards. The last screening we did was at the 3-year time point. The outcome of all of that, very briefly and in huge summary, is that it was quite clear that if we used the model for a domestic bomb attack on a soft target, this modelling tells us that you'd expect about 10 times as many people to have a psychological injury as had a physical injury. And again, there's about 100 times more than people that died. So obviously we're dealing with COVID now, and we can kind of almost imagine scaling this level of impact up exponentially. So at year 1, we had more than 1,000 under 18s open to us to get support, more than 560 unique families, and more than 3,700 individuals. The screening helped us identify people who were at risk, so suicidal people. So 7% of that number reported feeling suicidal more than half the days of the week, and half of those, we're talking over 100 people, had not requested any professional help until we had actually outreached and asked them how they're doing. So then we had to do something about it. It's really important to respond to what the service users felt they needed and wanted. So something we did a lot of in the early days was offer advice and consultation. We went to schools because lots of schools were asking, how do I talk to the young people? What do I say? What do I need to be aware of? And we ran a number of national conferences to support education providers. We were also asked to provide resources that were bespoke to the incident. and the one on the bottom left there is a great resource that was funded by the We Love Manchester Emergency Fund, and it helps young people and educational establishments think about the impacts of trauma. The bottom right shows some virtual reality footage of the city room foyer where the explosion was, because lots of people were asking us to go back to the site of the incident because they were quite frightened about going back for the next concert. So as part of a graded exposure, we augmented people's treatment where it was desirable with both virtual and actual visits back to the site. And then on the top right, you can see that we ran a lot of peer support. Peer support was really valued by those affected. Lots of people were saying they were the only people in their village or the only child at their school who went to this concert. They felt very disconnected. They wanted to share space with people who had the same lived experience. So we put on a number of recovery workshops, very clinically supported, with large numbers of people attending. We focused on communication between family members so as not to avoid the trauma that had entered the family. And we kind of ended on these positive things where people were building their own resilience boxes and writing their own messages of hope. Then, as we all know, early last year, COVID-19 took hold of the UK. And we were approached over a year ago by the partnership in Manchester to say, do we think we could offer something similar to what we've been offering to those affected by the arena incident to the health and care workforce? And it was quite clear to us that there were similarities. We are talking mass casualty incidents, we are talking high volume trauma, but clearly there are also some differences. Some of those differences are things like the fact that the arena had a very discrete beginning and end. We knew that the incident was over within a few days and the recovery phase could start. That's not the case with COVID. We're all kind of still in it, lingering towards the end of it, hopefully, but we don't know for sure. Also, the professionals that we supported from the arena were only mainly impacted by the arena within a professional capacity, whereas obviously now with COVID we have lots of people who are personally impacted as well as professionally, and that's fairly unprecedented. We had a lot more control, if you can see in the bottom left, over the information and advice that we were putting out into the system. It's really important to take control of the information that's going out there because it's not all great quality. Whereas, as you can see in the bottom right, with COVID, there's basically been a bit of an information overload and deluge, and you might want to spend some of your time curating the information that's out there. So one of the things we thought we'd do is we would lift the outreach and screening. Again, we wanted to let these staff members know that we were thinking of them, that we were there for them, and we invited them to take part in a digital screening similar to the arena. Now, there are challenges because the professional cohort are not like working with members of the public, which is whom we primarily worked with. And you know, they're fairly reserved, they're fairly stoic, and they were amongst the last people to ask for help after the arena. And what I should have said about some of the clinical outcomes was that people who took part in the screening and the triage and assessment work sooner tended to be less complex, and they tended to have much better outcomes. The later people left it, the more problems they had, and the harder it was for us to get them the right help. So as I said, maybe developing resources suited to your own workforce needs. You'll all know your own localities. There's something to be said about keeping things simple. So some of these documents we've got here are one-siders or two-siders, because we did find that people were getting overwhelmed. So you can have a look on our website at some of those. There are some webinars, some talking heads. We try and have a variety of resources available. The other thing that we wanted to do was replicate this idea of peer support. So people who are working together in this very challenging environment to help look after one another, because we know that's probably where most of the help informally exists. but maybe having it clinically facilitated in a structured way would be the best of both worlds. So we did something that we'd always done, but we had to do it in new ways. So we had to have people on digital platforms to bring them together virtually, to kind of offer some space where they could safely reflect as groups. We'd anticipated that people might want to be in mixed groups, so maybe we'd have a group for care home managers and they could talk to other care home managers. But actually what we found in practice is that most of the peer support we offer, the groups are already known and established groups. There are already existing teams that are struggling, that want some support as a whole team. So we have honoured that. And the last thing that we did for the arena, and that we've tried to emulate for the health and care workforce, was the whole family approach. Now, we knew from the arena and we know from literature that it's really important for the people that you support to know that they don't have to worry about their families. And we had lots of healthcare staff worried about their families, and we had lots of families worried about the healthcare member in their household going into these COVID environments and, you know, being self-isolated for weeks on end on shift patterns at the Nightingale hospitals, etc. So we offer screening support and onward referral to everybody in the household of the people that we support. And before anyone gets too anxious about this, the uptake of this part of the offer is not very huge. We've had very small numbers, but it has made a real difference for the healthcare worker where we have intervened in the family. Now, I appreciate that there's going to be lots of questions, so we have got 20 minutes for questions shortly. But it's been a challenge moving from a primarily public focused work stream into taking on this staff and public sector focused work stream. There's layers of complexity, and I'm going to hand you over now to Helen, who's going to talk you through and reflect on some of the challenges, both past and present.
Thanks, Alan. Hello, everyone. My name's Helen Lambert. I'm the service lead at the Greater Manchester Resilience Hub. As Byron alluded to earlier, I've got a relationship with PCMIS going back to when I worked as a commissioner and commissioned one of the first waves of IAPT and the first national pilot for children and young people IAPT, before going on to set up the military veterans service, where I started working with Alan, and then came to do the set up the Greater Manchester Resilience Hub. So I feel like I've been managing complexity for a long time, really. So I could talk to you about the complexity of the work that we do in the hub for a very long time, but I'm going to try and just give you a few high level areas to think about. And then, as Alan said, we're happy to answer your questions, because I think very often people have quite specific questions. But I think for me, that there are a range of areas of complexity to manage when you do this kind of work. I think one of the obvious ones is the external relationships here under network and collaboration. We work with a lot of different organisations, some of whom are very keen to work with us, some of whom are less keen to work with us, some of whom are cautious and have a lot of issues that they would like us to work with them on. And I think that it's important to take the time to build those relationships. It feels to me, it's one of those things that we all know. All the management literature tells you that, all the change management literature tells you about taking the time, investing in relationships. We also know it from all the trauma-informed lens work that goes on in service delivery, but consistently it feels we don't actually do it. And when you try and do it, it really does feel sometimes like you're swimming upstream, and there are a huge amount of pressures for you to move very quickly. But I would say one of the things that I think we have learned is do what you can to resist some of that pressure and really invest the time in the relationships with people outside your own organisation and the people who are your key partners. I mean, I'll give you one example from the work that we've done, setting up the staff wellbeing COVID-19 response. In the early days, we were asked to move very quickly to do to get something up and running. There was that sense of urgency about doing something. And one of the groups of people that we weren't able to work with as closely as perhaps we would have wanted to were the HR directors from the NHS trusts in particular, across Greater Manchester. Needless to say, they were very busy as well, so it was difficult to find the time. But then when we came to wanting to do things like Alan's described about the outreach to staff, and we were asking about, well, could we have the work email addresses of a lot of the staff who were working in at least ICU, HDU, acute respiratory, there was a real reluctance to engage with us, and over and above the normal data protection requirements, because we had all of that boxed off really. There is partnership working agreements, we had the information sharing protocols, but there was still a real reluctance to work with us in that way, which was quite difficult. It's taken a lot of time. I've been to a lot of the HRD's meetings, and there's clearly they're very concerned about the well-being of their staff, but they also want to understand how things fit together, and that takes time to explain the complexity. I'm pleased to say that I think we've moved to a very different place now, and the last time I went to one of their meetings was at their invitation, because they wanted to work with us and us to share our learning with them, to help them think about what they needed to do when staff were coming out of the pandemic and immediately being pushed into dealing with waiting lists and demands for initiative clinics and those types of things. But it has taken a lot of work to get through to that point. I think sometimes that some people think less about some of the internal relationship management that needs to be done. And I do think that for those of you who are setting up hubs, particularly if you're hosting a partnership service like we have done for both the Arena attack and now for this piece of work, it really does challenge the organisation who is hosting you, because most of our organisations are set up in order to deliver services which they are commissioned to do as one organisation. I mean, again, as Alan's alluded to, one of the key reasons that we keep going back to PC Miss is how easy it is to use for a service where you've got people wanting to access it from more than one organisation. Because if we give them a password and provided they're coming in through an appropriate secure connection, people from different organisations can use the same system and share that information. But I think there's a raft of other areas that we've struggled with around finances, around IT, getting people onto systems. And one of the big areas is governance, actually. And it's been quite a challenge with the staff wellbeing piece of work around how do we maintain the confidentiality when we're supporting all staff, including the staff in the organisation that we're actually based in. How do we maintain confidentiality, but also manage sharing information when it's appropriate to do that? And it really does stress some of our corporate colleagues out when we take them some of the issues that we need them to think about and help us work through. And then I think finally, I would just say something about the complexity of working with, putting a team together to do this kind of work, and those individuals. I think it's been, again, particularly challenging for some of our clinicians with this piece of work, because very often we're providing services to other people. Interestingly, when we set up the hub after the Arena attack, we specifically asked people whether they'd been directly impacted by the Arena attack. And we had some very, because we'd taken a decision that if people were directly impacted in those early days, perhaps it wouldn't be helpful for them to come and work in the hub. If we didn't have any of those options when we came to set up the staff wellbeing service, we are all NHS staff. And as Alan's alluded to, all our families have been affected in different ways. So, and we're working with people who are us, as opposed to the patients or the other people that we're working with. They are people like us, they are our colleagues, our friends very often. And so that's a challenge, I think, that needs thinking through. And also that we're asking people, again, like I've alluded to about the time, we are asking people to do things differently in the Resilience Hub, particularly if they're coming in from an IAP service, a CAM service, a CMHT. It's a very different world. And we have noticed that the transition for a lot of those staff is not always straightforward, because they can feel very de-skilled initially. I mean, people are professionals in their area. They're used to the systems that they work in. They know how to do the work that they're doing day in, day out. They come to the hub and we're constantly asking them to do things that they're less familiar with, or to think about things, or to ask them to solve problems, which are not the kind of problems that they're used to solving. And so actually taking care of your staff and practicing what you preach a bit can be another area of complexity. I'm aware that we've got to the point where there's 20 minutes left for questions and answers. So I'm happy to say a little bit more about any of the things that I've touched on, but I think I want to leave plenty of time for questions, so I'll stop there.
Hello, thank you so much for such an interesting presentation. It certainly provoked a lot of conversation and questions. If I could please invite Byron George back on to the screen, and we will commence with the questions. That's great. Hi, Byron. Hello, Helen. So I've got a screen actually to my right, so I'll be reading the questions off of the screen if you see my eyes wander. And the first question is for the Resilience Hubs for Alan and Helen. So it's how to implement peer support within acute hospitals.
Lots of grit and determination. I think one of the first things we did, which I would advocate, is that you do have most acute hospitals do have mental health colleagues based within them. So we very much made contact with psychological medicine teams, psychiatric liaison teams, people who already had relations with our acute colleagues as a way in. And then through them, we invited people to meetings to talk about the idea. And then we proposed a model. And basically what would happen is people would express an interest. We'd then email out a group of people who expressed an interest with possible dates and times. And then usually the response would be about a third. And then that would be enough for us to set one up, and we would just book it in. And initially we had 2 co-facilitators because we were still finding our feet. And we were involved in some of the piloting of the national common rooms that were available in the early days. So we kind of borrowed some learning from there as well. But what we found is that not everybody wants to engage in all parts of the offer. And it's been tricky. So where groups have taken part, it's groups that maybe we hadn't thought about in the first few days. So we have groups of chaplains. We have groups of bereavement nurses. We have groups of chief operating officers. So people with similar responsibilities or job roles, but they already do know each other and do have relations.
Okay, thanks. So the next question is for you, Byron. It's popped up. Which measures are patients currently entering?
That's a great question. It varies a little bit. I think, to be fair, a lot of the hubs we've set up so far have obviously taken advice and guidance from Helen and Alan, and quite often it's a light touch. I did see there was a question popped up about capturing the IAP MDS, and I don't think it's about that really. As much as we support some IAP services using the hubs, and there are many services that are not IAPs that are using the system as well. And it's more of a light touch do sufficient screening to be confident in terms of referrals. But it's, many are not using a full IAP model. They're using sort of best practice around, say, the depression measures and anxiety, but not necessarily the full IAP, which an IAP service obviously would do, but not the resilience hubs. Is that fair to say, Helen, Alan?
Yeah, I think you're right. I mean, certainly for the arena, we didn't use the full impact of events, which was what was available at the time. We just did a trauma screening questionnaire, like a 10-item, because Byron's right, the hubs just need to know enough to screen that somebody's likely to be in a clinical range and therefore would benefit from onward referral. So we try not to duplicate too much.
Yeah, and I would add that we are not an IAPT compliant service in the hub. When we set up the Military Veterans Service, for example, we were an IAPT compliant service. So we did enter and flow IAPT data, but we've never flowed IAPT data from the Resilience Hub, not least because we're an all-age service, but also it hasn't been appropriate for a range of reasons.
Thank you. The next question that I've got here is, do you have any ideas about whether you have missed people by having an opt-in screening? Apologies. Do you have any ideas about whether you have missed people by having an opt-in screening? I appreciate you're working with huge numbers, but we're planning on a screening of a workforce of around 4,000 people, maybe using holistic needs assessment type tool and training line managers to administer it to staff.
I'll let you go first, Helen.
Well, I was just going to say, I think we always miss people. I think one of the things we learned from our, we've worked very hard on communications, and we're still always finding people who say that they don't know anything about us, and staff in our own trust don't know anything about us, when I know that they're regular computer users, and one of our screensavers, one of the that comes up is about the hub. But people, especially when they're as overloaded as they are currently, simply don't see what you do. So I'll let Alan say a little bit more about the screening bit. I think we've had quite a lot of discussions about how you screen people, and about the issue about who does the screening and whether people can screen in effect anonymously, whether they can opt in to screen anonymously on our screening portal, courtesy of PCMIS, which works for some people. But I think choice is really important in this, because I can think of there are people who wouldn't opt in to come online, but actually if they sat down with a line manager or indeed a clinical supervisor or a occupational health or staff wellbeing person, might well complete the screening, and it might be helpful for them to do it. There are other people who would, I think we know from some of the risk assessments we've been obliged to do in the NHS for our staff, people don't necessarily want to share that information with the people that they work most closely with, and that people do have concerns sometimes about what they share at work, whether directly with their line managers, supervisors, or with occupational health. So I think having those choices increases the likelihood that you will catch as many people as possible.
Yeah, I'd just like to say, in addition to that, our goal is to offer support where it's needed and not to mandate that people do the screening. And most of our activity isn't as expected, because most of our activity has been through consultation, informal support over the telephone to managers, supervisors and leaders, and delivering staff team-wide workshops. So we kind of know that everybody gets something, but they don't need to necessarily come through as an individual and complete any kind of clinical measures. But absolutely, I think we miss people. I mean, we do our demographics, and I can tell you that in GM, there's about 25% of the workforce are men, and only about 9% of the uptake has been from men. So we're not hitting all of our target audiences. We're working on it. You can share some best practice back with us if you do it better.
Actually, that's a really good point. You have shared your details on your slides, so please do feel free to reach out to Alan or Helen or Byron after this webinar if there are any further questions that you do have. But with that in mind, so I do have a question for you, Byron. It popped up. How do you deal with the differing requirements between staff wellbeing pathways and the standard IAPT services you work with?
That's a good question. I guess one of the important parts, and I think it touches on one of the other questions, is in sort of terms of the involvement especially around staff confidentiality and the conversations around, certainly with Trust HR as well. And I think Helen just alluded to that as well. The confidentiality is obviously a very important factor. So we do offer different models, and there have been certain trusts have discussed the merits of being able to link to a wider clinical record, and also then the concerns of doing so. So we do offer the flexibility to be able to configure in a secure, separate system, and the ability to run the resilience hubs to maintain that confidentiality. And I think that going forward, I think a lot of services, even IAP ones, are running the system in a protected area just for the confidentiality of the staff record. Especially because potentially you could have staff within IAP that are referring into service, and that confidential is obviously an integral part of the service delivery. Does that answer the question?
Yes, I think so. But if the poster would like to follow up, then absolutely, I'll read it. And then, so I've actually got another one for you, Byron. Sorry to put you in the hot seat. I've got, what reporting is currently available in PCMIS for staff wellbeing pathways?
That's a good one. So we certainly are working, we're putting together a national key performance indicator. So we're working with across all the resilience hubs currently using the system to, and NHS England in terms of a national benchmarking report. So that's ongoing at the moment. Hopefully that should be available in the next week or two, but it does allow services to have a consistent approach in terms of evaluation.
So I've got, this is
Helen,
for Alan.
say something to Helen.
Yeah, I was
sorry.
Just say, because Byron may be a little bit too modest to say, that one of the great joys of working with PCMIS is that you can create your own reports in Excel and download them and manipulate them yourself to ask kind of questions that you didn't know when you set the service up you'd ever be asked or need to know. So some of that flexibility and being able to do your own reporting with even relatively limited IT skills like I've got, but I've got some great admin people who've got much better ones. But it makes it a very easy to use system and very responsive.
That's great to hear. Thank you. And apologies for interrupting. So the next question is for Helen and Alan. So it's, thank you so much for sharing your work. It's great. You mentioned that those in need being the individuals who typically don't access and resulted in more complex needs. I'm curious to understand, is there any good practice beyond having the hubs that have developed this population being more willing to access services? We have several hubs across the city and would recognise the need to encourage access to support sooner and in a more preventative way. Any learnings welcome?
I don't think we've cracked that one, if I'm honest. We're still trialing things. Some things were more advantageous than others. Certainly having some credibility with the groups that you're in reaching to goes a long way. So think about the staff that you're recruiting. So we've recruited staff to deliberately in-reach to critical care, for example, and to have credibility with those groups of people, you kind of need to know a little bit about their world. So yeah, and I think modeling helps. So we also found that targeting some quite senior people in those hard to reach groups, if they were willing to be seen to be accessing us because maybe they've done a talking head or they're on a webinar with us, then we do tend to see a bit of an influx in referrals on the back of those types of initiatives. But it's slow and steady work. And to be honest, I think a lot of staff feel that the emergency is not over and they're already worried about other pressures in the system like elective surgery targets, etc. So they're not quite ready to let their guard down yet and connect with their own vulnerability. So I think time is also an important factor.
And the only thing, one of the things that I think we've had some good feedback about is where we've tried to give people some idea, either through the webinars and occasionally through our resources, about what our normal response is to traumatic. and how long they might last, and when you might want to think about getting some additional help, because I think it's difficult for people to know what's a normal response, and we're very clear that we don't want to pathologize normal responses, and that there's messages about it being okay not to be okay, because actually if you were okay in some circumstances we might be more worried about you. Those types of things, but helping people understand what would be a cause for concern, and also helping people think about how they might broach some of that with their colleagues, because I think another thing that's quite common for a lot of professional groups is that they are worried about their one or more of their colleagues, but they don't quite know. They say, how are you? And they say they're fine, and they don't know where to go next. And I think one of the things that I talked about in the team is that, we've had to learn quite hard, quite quickly as a management team in the hub about how we do that internally with our own teams. And I think what we've tried to do is provide some of that learning in the system so that the people closest to other people can have better conversations with them.
Well, thank you. I have got, it's a two-part question. So it's, thank you so much for sharing your amazing work. We are learning a lot from you. Actually it says, how can we get in touch? I'd like to ask a few questions as possible. That is fine, isn't it? We can share your details. That's fine. Fantastic. And then it is, what is the nature of clinical presentations that you are seeing in the hub? For example, PTSD.
So we've got over 500 individual staff open to us on a one-to-one support basis, and about 60% of those are within the clinical range, as most of the audience would understand. Not a huge number have required onward referral, but the types of presentation are as expected. There's a lot of stress and anxiety. There's a lot of fatigue, which obviously we can't really prescribe rest for, but we'd like to. There's quite a bit of uncertainty because there's lots of changes afoot as well. So as well as COVID, there's moving away from CCGs and ICSs, etc. So there's lots of anxiety in the system. We are seeing a lot of kind of what we think of as morally injurious issues to do with shame and guilt about having to work in a way that is counterintuitive to one's moral code. So, wanting to save somebody's life, but having to let somebody not survive because there's only so much equipment and you have to prioritize. So we are seeing a lot of that kind of heavier end of a kind of trauma spectrum, but pretty much the whole gambit. So pretty much anything you'd normally see in a mainstream service, we're seeing here, and even just everyday concerns. Like we discovered that 20% of our clients have lost income into their households during COVID, and that's actually a real stressor in the household around where's the money going to come from.
Thank you. Thanks very much, Helen. So Byron, we've got a question. What resilience hubs are using the system, or is it just IAP services currently?
Yeah, I get built a little bit on what I said earlier. There's a mix. We do offer a number of options, and it definitely, it's fair to say, it's probably more non-IAP services than IAP currently. Some of the IAP services are using it, and a lot of non-IAP services are using it as well. So there is a bit of a mix. I think it's that flexibility, and going back to what I said earlier about the confidentiality of being able to configure the system. And I guess I've just spotted there's a question here around sort of the measures as well. And I guess there's going to be, there's a conversation to be had in terms of, if you want to avoid duplication against any IAPS referrals, you'd need to then consider sort of an integrated model rather than not necessarily a fully confidential one. And you need to have a balance between the two. I mean, if you do want to avoid any duplication of, referral or screening data.
Thanks. So the next question is, are you referring staff on for CBT, EMDR trauma-focused therapies, or are they being treated in the hub by your team?
I think the national team expect the hubs to facilitate treatment. So some hubs have staffed themselves up to deliver it directly. In GM, our original model was to utilise the IAPT workforce because they've now had their uplift to help expand that workforce. We also have, and all of the hubs will have access to practitioner health for regulated healthcare professionals if the IAPT's not appropriate. And once we've kind of exhausted primary, secondary and the practitioner health offer, then we do have a small treatment capacity in-house that we use. And in terms of intervention, yes, it's always NICE compliant. So we would offer things like CBT, EMDR, etc.
Thanks. I've only unfortunately got time for one more question. I am so grateful for everything that's been coming in, and please do feel free to email us if there was something that wasn't answered. We'd gladly forward that on for you. So the last question is, are you submitting your outcomes anywhere? Is it part of IAPT's performance data, or does it go somewhere else?
No, we're not. Well, we are reporting to NHS England now. As an NHS England commissioned service, there is a monthly KPI template that we report some of our activity against, which is, referrals, assessments, onward referrals to treatment, those types of things. But it's not part of an IAPT data set. We don't flow our data, and we haven't done at the hub. We're not an IAPT compliant service in that sense. But obviously the data from some of the people who we do, if we do refer on to IAPT, then we do tend to do, because we're commissioned to deliver assessments, then we will have done an IAPT data set because we're developing trusted assessment processes, which Alan might say a little bit more about, with the IAPT services, so that if we've assessed somebody that they do need CBT, EMDR, those types of interventions, we should be able to refer them directly to the IAPT waiting list, and they shouldn't need to have a further assessment.
Yeah, and we also report into the Greater Manchester system because they commission other services of support, such as bereavement support. So they like to collate everything that's happening.
And I think that concludes the webinar today. So thank you so much, Helen, Alan, Byron. It's been so interesting. I'm so grateful for your time.